a minute more and we should be on, ladies and gentlemen. Well, good afternoon, ladies and gentlemen. Very unusual times, very unprecedented times. I'd like to start with wishing all of you the best of health and all safety in the challenges that we will be facing as we go forward in dealing with this unprecedented history. May I request all those who tuned in to please mute your mics, except for those who are speakers. We will be recording the meeting and we hope to have it available by a website of NEESAMA, which will hopefully be live soon. We'd also be in a position to share the slides with you. So on behalf of NEESAMA, which is the Northeast England, South Asia Mental Health Alliance, welcome to the second of the NEESAMA webinar series, which is on difficult to treat depression. My name is Shekhar Seshadri. I'm a child psychiatrist working at the National Institute of Mental Health and Neurosciences in Bangalore, in South India. We have 3 speakers today. Going third and last will be Dr. Madhu Bhashini Dayabandara from the University of Colombo. Madhu is a psychiatrist who trained in Sri Lanka and in Australia, and she currently heads the Department of Psychiatry in the Faculty of Medicine in the University of Colombo. She works in the National Hospital in Sri Lanka, which is the largest tertiary care hospital in Sri Lanka, and which is a huge catchment area. And she works in some of the major areas of psychiatry, particularly major psychiatric illnesses, including depression and bipolar disorder. Going next will be Muralidharan Kesavan, who is Professor of Psychiatry at the National Institute of Mental Health and Neurosciences in Bangalore, India. Murli is a postgraduate from NIMHANS itself. He did a fellowship in Vancouver, deep interest in mood disorders, depression, non-invasive brain stimulation techniques. Murli also is an able administrator. He's currently the deputy medical superintendent of this very large hospital that he works in. So he balances both his enormous clinical duties with an extraordinary amount of administrative work also that he does. But going first, ladies and gentlemen, is Professor Hanish Mcallister Williams. Hamish qualified in medicine from Edinburgh in 1987. Extraordinary amount of work in serotonergic mechanisms in mood disorders. A lot of his earlier research and preoccupation was around serotonergic systems, till he reached a time where he was basically appointed as professor of affective disorders in 2017 at Newcastle University. And he's the lead now for mental health, dementia, and neurodegenerative disorders research team at the university. So he has focused a lot on the pathophysiology and the treatment of both bipolar disorder and unipolar affective disorders, other than working clinically in the tertiary level specialist regional affective disorders service in the Cumbria, Northumberland, Tyne, and Ware NHS Foundation. Now, the terms chronic depression, treatment-resistant depression, intractable depression, and now this term difficult to treat depression has had a long and a checkered history. But the current currency is for the term difficult to treat depression. And in terms of approaches, from an approach we looked at total symptom remission to optimum symptom control and functional improvement. What are the clinical challenges, the research challenges, and the treatment challenges in terms of medication, comorbidity, comorbid medical conditions that actually cause depression, other forms of treatment, including non-pharmacological treatment? So there's a whole framework of this enterprise and initiatives and concern that people have around difficult to treat depression across the lifespan. So this is not just with adults, it's also with children, particularly those children who have experienced adverse childhood experiences and have multiple and chronic trauma and what it does to persisting forms of depression, and also depression in the old age. So we are looking today in this webinar on difficult to treat depression across the lifespan. It is my pleasure, ladies and gentlemen, to first invite Professor Hamish Mcallister Williams to address you. Over to you, Hamish.
Thank you very much indeed, Shekhar, for your kind introduction. It's interesting because you emphasize some of the work that I've previously done around serotonergic neurotransmission. And what I'm going to be presenting today couldn't in many ways be further away from that perhaps rather reductionist notion of thinking about the underlying biology of mood disorders. Talking about difficult to treat depression, because this whole concept of difficult to treat depression comes from clinical pragmatism. And you mentioned that this is sort of relevant across the lifespan. It's also relevant across lots of different conditions. I'm going to be talking about difficult to treat depression, but it could be difficult to treat anything. And indeed, the model that I'm going to be presenting actually was based upon models that are used in the treatment of other conditions, physical health conditions, that can be problematic, such as rheumatoid arthritis. And I drew a lot of inspiration indeed from a publication looking at how you manage difficult to treat or poorly controlled arthritis. But it could be hypertension, it could be diabetes, it could be asthma, or it could be schizophrenia or bipolar disorder, or in this case, depression. So let me share my screen with you so I can show you the slides. And hopefully you can now see this that I'm wiggling my mouse around in, which is my title slide. I'm going to go through this presentation reasonably quickly because I'm hoping that we'll have plenty of time for discussion. And I will be pointing to one key reference that contains most of the important information from this presentation. So let's see if it works. That's interesting. Hold on, I can't get my slides to advance. Ah. So I may just have to present it in this view. So I'm afraid it's not giving you a whole screen view, but you can hopefully see the presentation clearly enough. Right. So let's see if we move from there. Right. So those are disclosures and interests. I'm not going to be talking about specific treatments. So I think these disclosures are probably not totally relevant. apart from to say that this piece of work that I was involved in doing in putting together this model for difficult to treat depression was supported by LivaNova, who are the manufacturers of vagus nerve stimulators. And you'll perhaps see why they are interested in this concept, but this model isn't there to sell vagus nerve stimulators. Hopefully that will also be fairly clear as I go through this particular model. So 4 points that I'm going to cover, and let's just start with the first one. Why do we need to worry about depression with poor outcomes? I mean, that might sound a pretty obvious question, because we know that depression is associated with very significant morbidity. It's a very, very unpleasant thing to suffer from. Of course, we're going to be interested in concerns about people who have poor outcomes, but just 2 facts that are worth just bearing in mind. The first one is that depression with poor outcomes costs healthcare systems a lot of money. So the greater the number of treatments that a person has failed to respond to, the greater the cost, the overall cost. So if you look at the orange bars here, you can see that the costs are going up with increasing number of, in this case, medication regimes that a person has not responded to. I suspect if you put there the number of failed psychotherapies, you'd have something similar. But in many healthcare settings, we don't have patients having multiple serial psychotherapists, but I suspect it would be the same. And I'm almost certain that it would be the same if you looked at various different neurostimulatory techniques, from first line ones like transcranial direct current stimulation all the way through to deep brain stimulation. Obviously, the latter is way more expensive than the former. The other point is that, very tragically and unfortunately, we know that depression is not just associated with increased morbidity, but also mortality, and it's all-cause mortality. You might immediately think about the risk of increased rates of suicide, and that is one of the factors that leads to increased mortality in depression. But we also know that depression is associated with increased mortality from physical health problems, including cardiovascular disease. This can be for many, many different reasons. We know, for example, that many patients with depression don't exercise as much as they ordinarily would, that they may well be, have high rates of obesity. There may be high rates of smoking amongst people who have depression, but there may be other factors as well that leads to increased mortality. And tragically, patients who have poorer outcomes have higher rates of increased all-cause mortality. So it is really, really, really important that we think about these poor outcomes. So let's just think about what the current concept is with regard to depression and its treatment. And this graph, most people, if you've ever been to talks about depression, you will have seen a curve like this before, or at least a similar version of it. Created originally by John Rush, first published by David Kupfer, both very eminent American psychiatrists. And what it shows is, it shows what would happen if a person moves from having no symptoms, developing more and more depressive symptoms until they're in a full syndrome of depression. Then they may have acute treatment, may start responding. By definition, a response is defined as 50% improvements of symptoms. So at that point, they may or may not be above this green dotted line, which represents where they may be fully syndromal and where they may not be. What we really want is to get people up into full remission, which is when they are essentially symptom-free, or at least to being close to being symptom-free. And we want that to carry on for a significant period of time, for a long period of time, at which point we would then say, well, they have actually met criteria for recovery. This sort of conceptualization is envisaging depression as a very simple episodic disorder, where people start with no symptoms, they have an episode of illness, and then they recover and are free of symptoms again. And hopefully that's it. Hopefully they have one episode and never have another one. What we know is that most people who have one episode do have at least one more. That second episode may occur a few months after the first one, a few years, or maybe even a few decades after the first one. So some people have good inter-episode functioning, long periods of time between episodes, and the depression behaves very nicely, neatly in relation to what the textbooks say. But the problem is, if you are a clinician or if you're a patient, what you know is that unfortunately this doesn't always happen, and that what can happen is that people get incomplete remission of symptoms, that they may have increased rates of relapse, frequent relapses, and symptoms wax and wane. They come and go, and there is an ongoing burden of symptoms over the long term for many patients. And that is a problem with regard to the way that we conceptualize treatment, because we conceptualize treatment as trying to treat these acute episodes that I'm showing you on the screen. And if the first treatment doesn't work, well, we try another treatment. And if that doesn't work, we try another treatment. If that doesn't work, we try another treatment. And the question is, how long do we keep on trying lots and lots and lots of different treatments? And is that the right paradigm? So what is DTD, or difficult to treat depression, and how does it compare to the more conventional, traditional definitions of treatment-resistant depression? Oh, that's not going to work because I need to make this animate. I'm going to try again, seeing if I can actually make this animate. Oh, yes, okay, right, that's better. Now, this is data from the STAR-D study, which is a very, very large American trial of the treatment of various different treatments for patients presenting with depression. At step 1, where there was over 3,500 patients included in the study, patients were treated with citalopram. If they didn't respond to citalopram, they could go to step 2, where there were a number of different treatment options. And then if they didn't respond to that, they could go to step 3, at which again, there was a number of options, and then they could go to step 4. And for each of these different steps, 2, 3, and 4, there was actually no statistically significant difference between the effectiveness of any of the treatments studied. There was a few differences with regard to tolerability, but nothing with regard to efficacy. So in this slide, I've lumped together the outcomes of the people, the patients that were in this study, irrespective of what treatment they had, but just whether they were having this first, second, third, or fourth line. And what you can see is at step 1 here, about 40% of patients went into remission, i.e. they were symptom-free. That means 60% didn't. So that's illustrating our first problem. We've got a significant number of patients, indeed the majority of patients don't go into full remission with the first treatment. Then we look at step 2, and again, we're getting about 35% of people into remission. Step 3, well, it's down to about 15%, same at step 4. So what we're seeing is a reduction in the rates of remission with successive treatments that are tried. And this is by far and away the largest data set that has ever looked at this, but everything else that has shows similar findings. If you look at individuals who have failed to respond to a number of different treatments, the probability they will respond to the next treatment, unfortunately, is significantly lowered. But what sometimes people forget is that if you look at these same groups of patients and we look at the rates of relapse, we see the complete opposite picture. And basically, the harder it has been to get somebody into remission, the more likely it is that they will relapse. So we're seeing increasing rates of relapse with successive treatment trials. And then thirdly, if we look at the tolerability of the different treatments, we see increasing rates of intolerance shown in these green bars with each successive treatment. Now, again, that's sort of rather obvious because we're going to use a simple, well-tolerated treatment first line. And if people don't respond to first, second, third line treatments, we might be looking at treatments that maybe are less tolerated, but a patient might still respond to. So that's perhaps no great surprise. But when you look at those 3 lines, you can see that there's a major problem, and which I've referred to here as a triple whammy, that as people go down various different treatments, it's starting to become harder and harder, not just because of problems getting into remission, but also because of increased rates of relapse, and thirdly, because of increase in tolerance. And it's really important to remember that poor outcomes for patients come about not just because of a failure to respond to treatment, but also because of a failure to retain a response or remission, i.e. they're relapsing after an initial response. And that is not taken into account at all by traditional concepts of treatment-resistant depression. Treatment-resistant depression is all about serial acute treatments that you keep doing until the patient gets into remission. So that led people to think, is TRD the most sensible conceptualization of how we should be helping patients who have poor outcomes? And John Rush, who led the STAR-D study, has been involved in proposing that we should think about this concept of difficult to treat depression. And I can highly recommend this paper that introduces the concept from the Australian New Zealand Journal of Psychiatry from 2019. Just to try and illustrate and describe what the differences are between TRD and DTD. First of all, I think there's a semantic difference. Semantics may not be the most important thing, but I think they do have importance and relevance. TRD, the question is who or what is being resistant? Are we blaming the patient? Are we blaming the illness? It does smack of clinicians saying, well, it's not us. It's down to something else. It's treatment-resistant depression. Difficult to treat depression is saying something a little different. It's saying that it is difficult. It's difficult for the patient, it's difficult for their family, and it is difficult for the clinician. And we're all in this together. It's a collaboration between the clinician and the patient in terms of managing the problem. Critically, the models that are being used are very different. TRD is taking an acute episodic illness model, whereas difficult to treat depression is taking a more chronic illness model. And I repeat again, this model is based upon the management of chronic physical health problems like chronic rheumatoid arthritis, chronic diabetes, chronic hypertension. These are conditions that don't just come, are treated and then vanish and go away entirely. They wax and wane. You can get these conditions under control. You can help improve patients' lives, but you have to recognize that these are long-term conditions. In terms of definitions, TRD is defined on the basis of failure to respond to an acute treatment. Most commonly, and there is no uniform single definition for TRD, but most commonly it's defined as failure to respond to 2 adequate trials of pharmacotherapy. Most TRD definitions just ignore psychotherapy and ignore neurostimulatory treatments, although a few do include non-response to ECT. DTD is a much more pragmatic definition, and it's talking about the lack of an acute response or a lack of a sustained response. It's really important that it's not just getting people better, it's helping them stay better. The end point, instead of just being symptoms as it is for TRD, it's saying we need to be thinking about function and quality of life of the patients, because that is what is really important for them. And in terms of management, this is where it's really different, because TRD is saying, well, okay, that treatment hasn't worked, let's try another one. That may be entirely appropriate in certain situations, but there may be other situations where you have to say, hold on a second. Do we just keep going ad infinitum through all of the various different treatment options? Or do we say, hold on a second, let's just reevaluate and try and understand why this depression has been harder to treat than we would have ideally liked. Some patients' depression, fortunately, is easy to treat. We give them an antidepressant, for example, they respond really well, they go into remission, we don't need to do anything else than say, carry on with that antidepressant for a period of time, and then you could potentially come off it. But for some patients, that just doesn't happen. So we need to say, what is keeping this depression going? What is making it difficult to treat? And is there something there that we can do something about? So How do we manage difficult to treat depression? So I was very fortunate and privileged to be a member of an international group of psychiatrists from North America, Australia, and Europe who put together this consensus statement on identification, assessment, and management of difficult to treat depression. And in this paper, we came up with the definition of DTD as depression that continues to cause significant burden to the patient despite usual treatment efforts. And you'll immediately recognize that that's vague and pragmatic and will be defined differently in different circumstances. What constitutes significant burden? Well, that's up to the patient. And why shouldn't it be? Because it's the patient that's actually the one that's suffering from the depression. Despite usual treatment efforts, well, what does that mean? Well, it will mean different things in different circumstances. In primary care, it might be fewer treatments than if it was in a tertiary care center, such as the one where I work. But inevitably, that has got to be the case. Because if you are a primary care physician and only experienced in using 2 or 3 different antidepressants, if a patient hasn't responded to 2 or 3 different antidepressants, then it's difficult to treat for you. And you're going to need to look at what you're going to do, what you need to do. And that might mean referring on to somebody else. So it is necessary that you do think about the healthcare setting that you're operating in. So what we say is, first of all, the most important thing is when you suspect somebody is having difficult to treat depression is to do a thorough assessment. And in this paper, and you'll see on all of these slides, there's the reference to the paper, we make some recommendations with regard to physical assessments and also symptom rating scales. I'm not going to go through these. It looks like a big list. It's actually not that complicated. And we actually feel that it's quite a useful thing to have actually published this, because hopefully this does give people more guidance as to what constitutes a reasonable set of routine investigations, both in primary care and in more specialist settings. We then say you need to reconsider the differential diagnosis. Has a person got difficult to treat depression because actually they got bipolar depression, or they got depression secondary to a head injury, or secondary to a psychotic illness? If they have, and you're just treating it with antidepressants, you may well be struggling to help that patient get better. We then said it's really critical to think about comorbidities, because we know patients with depression are more likely to have comorbidities of all sorts. These can be mental health ones, so it could be comorbid anxiety, substance misuse, could be comorbid alcohol misuse. It could be physical health problems, so it could be comorbid hypothyroidism or heart disease or a painful syndrome. Any single one of these comorbidities, we know, makes it harder to treat depression and makes poor outcomes of patients more likely. So we need to identify comorbidities and treat them as much as we can. Some of them are going to be easier to treat than others. But the basic rule of thumb is we must try and deal with them as much as we can. So we've got to identify them first of all. And then thirdly, critically, coming back to this whole principle that we're trying to identify what is making the depression difficult to treat, we want to identify the predisposing, precipitating, and perpetuating factors, both biomedical, such as hypothyroidism, for example, as well as psychosocial. And we want to be dividing those as maybe or a way of helping us think about these factors. In the paper, we suggested you might think about patient-related factors. So they may be something around early life adversity or sexual abuse in childhood, for example. Illness-related, age of onset, chronicity of illness. We know these things impact on outcome. And treatment-related factors. How many different treatments a person has actually tried and not responded to will impact on what you're going to do next. Whether the patient is actually taking the medication is also going to be important. Whether they've been able to engage in psychotherapy, if that's been available. So trying to think about all the factors there that are going to give you, as a clinician, some handle on what may be making this individual's depression harder to treat. And then we came up with this scheme of 8 key items to think about how we manage it. And again, I'm going to go through this very, very quickly, so I don't overrun on time too much. Let me blur it up, but you can go into the paper for more details. So the first one is about achieving symptom control using measurement-based care. We know if you measure people's symptoms, their outcomes are better. And in this section, we emphasize the importance of all the conventional treatments, be they medication, be they neurostimulatory treatments, be they psychotherapies. The importance of then thinking what we might do if somebody fails to respond and remit and remain well after first-line treatment, and that might be increasing a dose of a drug, switching to a different drug, adding in a second drug. We might be thinking about adding in psychotherapies or different types of psychotherapy. We might be thinking about starting neurostimulatory treatments such as ECT. And if that doesn't work, we need to remember that we're getting an increasing number of non-conventional treatments. We've used the term non-conventional to really describe the treatments that are currently beyond current guidelines. And examples of that at this moment in time would include things like vagus nerve stimulation, deep brain stimulation, S-ketamine, something that's recently being licensed around the world, or IV ketamine. So it's thinking about some of the less conventional treatments. So it's trying to think broadly, widely about all the different treatments that we can think of, and we want to optimize symptom control. If we can get to remission, brilliant. But even if we can't, we want to optimize symptom control. Next point is thinking about targeting symptoms associated with poor outcomes. For example, we know both anxiety and pain are associated with poor outcomes. So if people have these symptoms, are there specific treatments that we might be thinking about to try and deal with those symptoms specifically? Thirdly, we want to be targeting symptoms that we know impact on quality of life, such as sleep problems, fatigue, cognitive problems. We know cognitive problems are associated with worst functional outcomes for patients. So again, are there any treatments, techniques, strategies, psychotherapies, neurostimulatory techniques that might be able to help with any of these particular problems? We want to identify the comorbidities. I've already mentioned that, but it's absolutely critical. And we want to optimize long-term outcomes by ensuring adequate prophylaxis. Once a patient has been helped to get better, we've got to do whatever we can to try and keep that sustained. Then, point number 6 is thinking about self-management. I cannot emphasize this enough. I think it is really important because it helps empower patients to take some control of their illness. For patients with difficult to treat depression, it is rarely simply about which medication to take or even which psychotherapy to use. It is about a combination of different things, medications, psychological techniques, and lots of other things, behavioral activation, keeping active, having strategies and schedules to follow through the day. So there's a whole list of things shown on that slide that are important and can be important for patients to think about themselves. We want to make sure that we've got integrated services. I think this varies massively between different countries. I would have to say in the UK, I think we struggle with this because I think we have a massive gap between primary care and secondary care. Primary care are very good at dealing with first, second line treatments for patients with depression. Secondary care can be very good at dealing with patients who've got more complex, difficult to treat depression. But there's lots of patients between these two extremes that get rather left out and neglected and are often sort of languishing at home with suboptimal outcomes. We also need to establish regular reviews. And again, I think this is really important. I don't think this totally fits with some of the models that are used in the UK for treatment, which involve, in secondary care that is, where there is an idea that we give people packages of care, and then once they've got reasonably well, we discharge them back to primary care. The idea here is that you review every, 6 months, year, and you reassess the level of symptoms, the level of functioning. We reconsider the diagnosis again. We screen for comorbidities. We review all the predisposing, precipitating, and perpetuating factors, and then review all the medications, psychological therapies, and any other treatments that might be relevant. So it might look complex, but actually, I don't think that's a million miles away from good clinical practice. So it is revolutionary in one sense, in terms of our conceptualization, but I don't think it's that revolutionary with regard to what many clinicians would see as being reasonable clinical practice. So just to summarize, I'd say we want to optimize the management of depression for all patients. Everything starts with good assessment of diagnosis, comorbidities, and those 3 Ps, the predisposing, the precipitating and perpetuating factors. The goals for our treatment in DTD are optimizing symptom control, remission if possible, but recognizing that might not always be possible for all patients, minimizing risks and consequences of relapse and optimizing psychosocial function, and then principles of treatment. I list 6 there, which I've hopefully highlighted a bit in the previous slides, but we emphasize a bit more in the paper. Shared decision-making, engagement, self-management, measurement-based care, really important, frequent reassessment, and that integrated service pathways. And what I'd sort of finish by saying is it's about holistic management, considering all the options in as timely fashion as possible, and potentially that means bringing in extra support. That's the integrated service element. And my last bullet point is that. And then there was COVID, and I think that changes everything and doesn't change anything. COVID leads to lots of extra challenges for us providing healthcare. It leads to lots of extra psychological issues for individuals. You know, we're seeing a massive amount of increased health anxiety, not surprisingly. But I think that's just yet another factor in amongst all this. That just ends up being a perpetuating factor. So it's just something else that we need to consider when we're doing that holistic assessment of the patients and helping to manage them. So I hope I haven't gone on for too long, and I hope that sort of outlines what we were trying to achieve in the paper that we recently published.
Thank you very much, Hamish, for that. Ladies and gentlemen, Journal of Affective Disorders 2020, Hamish Mcallister et al. Is the source from which the major substance of what Hamish has presented in terms of the algorithms of how you approach difficult to treat depression are present. Questions, comments, your own experiences and thoughts, put them on chat. We will take them together after we finish the 3 presentations. Based on this model that Hamish has presented, let's move to Murli and listen to his perspectives on the whole conundrum of difficult to treat depression. Over to you, Murli.
Yeah, thank you, Dr. Shekhar. Thank you first to Hamish for a wonderful presentation and for introducing us to a concept of a more empathetic concept of treatment-resistant depression than what we have been used to. It's not very often that we get to hear about the concept from one of the people who introduced it themselves. So in that sense, it's been a wonderful learning experience. Thank you, Hamish, for sharing the paper and for taking us through the consensus statement on difficult to treat depression. So will probably be flitting a little between TRD and DTD in my presentation. Yeah. So I have no conflicts of interest to disclose, and I would like to take this opportunity to thank NEESAMA for giving me another opportunity to make a presentation to the group here, and some of my colleagues who've helped me put these slides together by sharing the information from their individual work. This is the outline of my presentation. I have a few slides on depression and treatment resistance, the Indian scenario with respect to depression. I'll go over to a few slides on the NIMHANS experience with difficult to treat depression or treatment resistant depression, particularly with a focus on non-invasive brain stimulation, ketamine, and yoga. And I'll leave you with a few points to ponder after my presentation. So depression and treatment resistance, as we all know, and as Hamish has also told us that it's a significant public health problem. It contributes to almost 4.4% of disease burden across the world. As you can see from this map here, almost all the countries have at least between 2 to 6.5% of their population affected by depression. Depression tends to run a recurrent course in about 50 to 80% of those who suffer from it. Chronic course in about 20 to 30% of the individuals. In terms of response to pharmacotherapy, we've already heard what Hanish told us about the results from the study trial and the kind of triple whammy that patients face. And of course, I'm sure you have not seen this slide before, so I'm showing it to you again. But the only point that I wanted to highlight was that this is probably the phase where a lot of patients are stuck in terms of their response to standard treatments. And it's the movement of the patient from a syndromal phase to a phase of complete recovery that is a significant challenge to both the clinician as well as the patient. So in terms of treatment-resistant depression, if you go by some of the definitions that are used, the prevalence rates are between 10 to 60%. They account for about 40% of the treatment costs annually. They understandably are associated with more burden than depression that is responsive to treatment, probably because there are more outpatient visits, greater number of hospitalization, there are more assessments that need to be done, more complex treatment regimens that need to be administered. The course of illness tends to become progressively worse. Functioning, of course, tends to remain impaired. And the suicide risk is always there. And that's one of the leading causes of death in people with resistant depression or people with chronic depression. Again, as Hanish pointed out earlier, the definition of treatment resistance was very broad. And there were a lot of terms that were used to describe treatment resistant depression. Not necessarily very clear. Most of the descriptions are not very clear, but two broad concepts have been used to define treatment resistant depression. One is medication failure method. The other one is the staging method. Medication failure method is something that all of us know. It's a very categorical approach, but also tends to be used more commonly because it's very convenient to use. So basically the medication failure method says that, if a major depressive episode that does not improve after at least 2 adequate trials of antidepressants from different classes may be considered as treatment resistance. And like Hamish already pointed out, there are a lot of limitations in the definition of treatment resistance. It's more pharmacocentric, does not take into account psychotherapy or non-invasive brain stimulus. And it's a very dichotomous kind of definition. The patient is either improved or not improved. So there's no dimensional approach to depression here. The staging method is another common method that has been used. Of course, it has its origins in oncology and has been adapted to psychiatric illnesses too. So staging method is another thing that has been used. The issues in defining treatment resistance, we don't have consensus on the number and type of treatment failures, what kind of treatments have been tried. There is also wide variation in prescription guidelines. For example, between two clinicians, you'd find that there's a significant variation in what would be considered an adequate dose and what is an adequate duration of antidepressant treatment. Measuring treatment outcomes also tend to become very difficult. Like, for example, do you measure using HAM-D or do you measure MADRS? Do you pay attention to the residual symptoms or do you pay attention to the symptoms that have already recovered in defining treatment failure? So there are a lot of issues in defining treatment-resistant depression. The other important thing that I'd like to point out, particularly for clinicians, is the concept of pseudoresistance. We need to be absolutely sure that we're looking at treatment resistance in a patient and not a pseudoresistance, which is the most common misdiagnosis. It's probably it's more easily identifiable actually than treatment-resistant depression. A lot of clinician factors contribute to it. Diagnostic issues, which could be a misdiagnosis of unipolar depression. We probably misdiagnose bipolar depression as unipolar depression very commonly. The amount of information that a clinician can get from the medical records of the patient, subtherapeutic dosing and inadequate durations of treatment could also be contributing to pseudoresistance. And in terms of patient factors, adherence to the treatment regimen that is prescribed is an important limitation in terms of understanding resistance. And of course, underreporting of symptoms and the severity of symptoms. So the risk factors of treatment resistance are, the clinical factors that themselves, the greater severity of depression, presence of psychotic symptoms, chronic episodes, residual symptoms, age at onset of illness, longer duration of illness, comorbid conditions, psychiatric disorders, particularly comorbid medical conditions like diabetes, mellitus, hypothyroid, which Hamish alluded to in the assessment and management of difficult to treat depression. And of course, certain other factors which can vary from country to country needs to be taken into account while we identify what could be the risk factors that are contributing to poor response to treatment in an individual patient. And of course, the steps were already outlined by Hanish, so I'm going to skip this slide. So coming to this reconceptualization of treatment-resistant depression as difficult to treat depression, I think it's a wonderful effort. It's a good, like I said earlier, it's a very empathetic way of looking at treatment-resistant depression, where we need to see, will this concept gain acceptance? So that's the key question here. People who are used to reading about treatment-resistant depression need to also reconceptualize TRD as DTD. That also becomes dependent on how much of literature can be put out as early as possible by the different groups that are working on difficult to treat depression. And I think this is one of the areas where the NEESAMA countries should take the lead in contributing to more literature on difficult to treat depression. So depression, the Indian scene. This has been the scene for quite some time now. Depression for long has been the elephant in the room that nobody wants to talk about in India. It's probably gaining a little bit more importance now than what it had in the earlier days, but then this is something that's very difficult to ignore. So if you look at the prevalence of depression in India, about 2.7, this is from the National Mental Health Survey that was done by NIMHANS as a lead investigator in the year 2016. Almost 2.7% of Indian population suffers from depression currently, and about 5.4% have had a lifetime episode of depression, which technically means that 1 in 20 Indians suffer from depression. So if you take that for a population of 130 crores, you get the magnitude of the problem, the number of Indians who are suffering from depression currently. And of course, if you look at the global burden of disease study that also involved Indian sites, you find that the prevalence of depression is quite high. It varies between 2,750 to 3,750 per 100,000 population. So that's the number of people with depression that we're dealing with on a day-to-day basis. Also look at the prevalence of depressive disorders across age in the Indian population. You find that it's about 2.5% of the general population. Females tend to have more depression than males across the age span. The onset of depression the prevalence of depression rather seems to be more common in women aged 40 to 49 years of age, while in men it's between 50 and 70 years of age. So that's the findings of the National Mental Health Survey. And the treatment gap is a significant issue. While a significant percentage of the population suffers from depression, only about 15 to 20% of them have actually been able to access treatment with a mental health specialist or a treatment with a primary care hospital that provides mental health care. So you can see that there's a significant treatment gap. The gap seems to be particularly more for depression and substance use disorders than for the other psychiatric disorders. So moving on to the NIMHANS experience. So this is something that I'd like to, this is from the latest annual report at NIMHANS. We see about 5.5 lakh patients per year. And the number of new registrations for the period of 2018-19 actually was about 20,000 new patients. So we see about, in that psychiatry is about 1.5 lakh patients, and almost, this is a very conservative estimate. So we would probably see about 15 to 20,000 patients with depression annually. And if you go by the prevalence rates for treatment-resistant depression, you could say that almost about 10 to 15% of them would be difficult to treat or treatment-resistant depression. So this is what we had in the last year, the number of new patients with depression. So we had, as I pointed out from the earlier slides, we had more female patients with depression reporting to NIMHANS in the last 1 year as compared to male patients. So in total, we've seen about 1,962 patients with depression. So what are the standard assessments that a person with depression goes to? Again, we use the ICD-10 diagnostic guidelines. Life charting method is followed for all patients with depression. Most patients that we see in the hospital, which again is a tertiary care center, are patients with moderate to severe depression. And about 25 to 30% of these patients would require inpatient care. And thereby they would get a more detailed assessment than what patients attending only outpatient services would get otherwise. The commonly used rating scales for standard clinical practice are the Hamilton Depression Rating Scale, the 17-item version especially. We also have made it a practice to run the mood disorders questionnaire to all patients who are getting admitted with a depressive episode, particularly if these individuals have a diagnosis of a recurrent depressive disorder. Like Hanish pointed out very correctly, bipolar depression is something that you need to be very, very cautious about. And mood disorder questionnaire helps us rule out bipolarity or establish bipolarity, depending on what your findings are. And standard assessments that we're doing these days for all patients with depression include the vitamin B12 levels, vitamin serum D3 levels, and the standard thyroid function test for all patients with depression. It's interesting that almost 70 to 80% of the patients who come with a depressive episode actually have deficiencies in these three blood parameters when we check them routinely. So moving on to the treatments that we offer for people with treatment-resistant depression or difficult to treat depression. I don't have too much of data or data that I can readily access with regards to psychotherapy services. I'm sure a significant number of patients are also using psychotherapy, but we do not have a centralized registry from where I can access this information. So I've stuck to just talking about brain stimulation treatments, some information on ketamine and yoga. So if you look at the last, this is about 5-6 months uh, before the lockdown happened, before COVID made it necessary for us to close down the hospital. About 143 patients were prescribed ECT between October 2019 and February 2020. So a total of 1,179 ECT sessions. These are modified ECT sessions that were administered, of which 33 patients out of this 143 were patients who were diagnosed with treatment-resistant depression by the treating clinician and referred for ECT. So about 304 ECT sessions were given to these patients. As you can see, while people with severe depression may get about 6 to 8 ECTs as a part of their treatment session, people with diagnosed with treatment-resistant depression probably were given a couple of ECTs more as a part of their regimen than what they would have got otherwise. Bifrontal electrode placement is what is practiced routinely here, and monitoring of cognitive functions is done routinely for all patients. From what I understand by speaking to the ECT team, almost all patients who received ECT for treatment-resistant depression showed remission at the time of discharge. So that is a very encouraging statistic that I was able to get from the ECT services. Moving on to transcranial magnetic stimulation, I'll focus a little bit about theta burst stimulation, which is what we are prescribing more for depression these days. And as you can see from the graph here, theta burst stimulation basically involves 3 bursts of very high frequency magnetic pulses, which when administered to the area of interest, which is the left dorsolateral prefrontal cortex for depression, can bring about symptomatic change and recovery. Theta burst stimulation is something that we have been using here for the last 3 to 4 years. So this is something that was published by one of my colleagues from the ECT team, the TMS team rather. So as you can see here, patients were recommended RTMS routinely between the period July 2014 to July 2016. And the number of referrals for TMS services were quite low because the efficacy of RTMS was questionable, and it required the patient to be seated in the ECT, in the TMS room for a long period of time. Enter theta burst stimulation. You can see that the number of referrals have jumped by almost 87% because the time spent for treatment is much lesser. It's about 2 minutes in theta burst stimulation as compared to 40 minutes for conventional for RTMS. So the treatment time, the amount of time that the clinician and the patient need to spend together came down significantly. So the use of theta burst has actually gained a lot of prominence at NIMHANS now. So I'll just briefly talk about some 68 patients who have received theta burst stimulation since April, probably since 2016, and about 28 have received since 2018. Most of them are in the age range of 13 to 85. 9 children below the age of 18 years have received theta burst stimulation, and 31, I wouldn't really call them elder, not the geriatric age group, but a lot of people who've received are above the age of 40 years. 5 of these patients had psychiatric symptoms, and 19% of the patients had major anxiety disorders as comorbidity. And the mean duration of illness was about 9 years. Yeah, so if you look at the indications for theta burst stimulation in depression, you find that 50% of them were referred for augmentation of their standard antidepressant treatment, whereas 29% of the subjects were referred for treatment-resistant depression, as we had defined earlier. Alternative treatment strategy, in the elderly, the reason for referral was poor tolerability of SSRIs or tricyclic antidepressants that they were prescribed, severe medical comorbidity which restricted the use of ECT in these patients. Some patients were referred because they were pregnant, and the treating clinician did not want to prescribe ECT. And for some people, it was prescribed as monotherapy as requested by the patients themselves. So when we talk about patient choice, we find a lot of patients who are well educated who come to us and who would prefer to receive theta burst stimulation or TMS. And we've had many such patients who. So from what we found was that 45% of the patients were clinical responders once they received a course of theta burst stimulation. And this compares with an earlier study that was published by Blumberger et al. And there was a significant drop in the Hamilton Depression Rating Scale scores. The only way that our sample was different from the Blumberger study is that we had more females in the subjects who received TDCS. We have also used neuronavigation guided site localization thanks to our software that is available at MHANS. And we've used supra-threshold theta burst stimulation for our patients as compared to Blumberger study, where they used threshold stimulation. So the safety, it was quite safe. There was no incidence of seizures in any of these patients, which is the most common side effect that one would expect with theta burst stimulation. We didn't have any seizures. Discomfort during the session due to the local muscle stimulation was the most common side effect. Only one person dropped out of treatment. And in children and adolescents, we had to do dose reduction in one individual, and transient irritability was noted in another one. But otherwise, all of them successfully went on to complete the TBS treatment for depression. So theta burst stimulation is becoming a very important weapon that we have in our arsenal in handling treatment-resistant depression. A few slides about bipolar depression, mainly for clinicians. A lot of times we tend to see people. See, in India, the course of bipolar disorder tends to be mania predominant. But a lot of times we tend to have patients who present with the first episode of depression. It's only after the manic episode that we are able to say for certain that this person is bipolar disorder. So to distinguish unipolar depression from bipolar depression, there are a lot of clinical signs that have been proposed. I've just put out one such compilation here. Symptomatology in terms of the presence of more atypical depressive symptoms, presence of psychomotor retardation, lability of mood and irritability, the onset of depression prior to 25 years, family history of bipolar disorder, all point towards the possible bipolar depression. And a recent article that was published, not very recent, a couple of years ago, there was this definition of treatment-resistant depression for bipolar depression, where a patient with bipolar 1 or 2 disorder and who currently fulfills the criteria for a depressive episode can be classified as treatment-resistant if they did not tolerate 2 different trials of drug treatment with the drugs listed here, at least 2 treatments in the box A, or at least 1 treatment in box A and 1 treatment in box B. It's a very good reference article, which you can read for understanding what could be treatment resistance in bipolar depression. So in that context, just wanted to share a study that we had done. This is actually a meta-analysis that we had published in World Psychiatry a few years back, where we looked at the acute treatment of bipolar depression with Rtms. And this is what we found. We found that Rtms was significantly more efficacious than a sham Rtms in bringing about remission and response, both remission and response in patients with resistant depression, resistant bipolar depression as compared to sham Rtms. And when we looked at the different types of TMS that were administered, we found that this efficacy was reported more with the high frequency Rtms to the left dorsolateral prefrontal cortex than low frequency Rtms or bilateral Rtms or theta burst stimulation. I'm sure there are more studies that have come up since we published this meta-analysis, but this is one of the papers that has been cited by most of the guidelines as treatment options for bipolar depression. Again, most of these studies were in patients who had resistant bipolar depression. A few slides about transcranial direct current stimulation, the NEMANS experience. So this data that I'm talking about is for the last 1 year, from February 2019 to 2020. Only about 15 patients have received treatment-resistant depression. So about 150 sessions of transcranial direct current stimulation have been administered. This is in contrast to 2,500 sessions that are administered annually, but majority of the patients who are prescribed TDCS receive it for schizophrenia or for obsessive compulsive disorder. The response rates with depression have not been uniform. There have been a few patients who reported improvement, whereas others have not really reported the kind of improvement that has been reported by patients with schizophrenia or OCD. So that also remains one of the reasons why TDCS is not used as routinely as it should otherwise be used. It's again preferred in patients who are elderly and have significant medical comorbidities. It has not been used in bipolar depression, because of the risk of switch with TDCS. So that's one of the reasons why we have been reluctant to use it here. And we do not have any patients who've undergone high definition TDCS in depression. High definition TDCS is something that is administered more routinely for OCD and schizophrenia. So this is the device that is used to administer TDCS, and this is the depression protocol. As you can see, the anode is placed on the left dorsolateral prefrontal cortex and cathode on the right dorsolateral prefrontal cortex at 2 milliamp stimulation intensity. The patient receives the session for 30 minutes. There's I think 20 seconds ramp up time and a 20 seconds ramp down time. Once daily sessions for a period of 10 days. So each patient is administered a total of 10 sessions. So moving on to a study that was done at NIMHANS regarding the role of ketamine versus ECT for depression. Again, this was done as a part of an MD dissertation a couple of years back, where 24 subjects were randomized to receive either ketamine or ECT. Ketamine was administered at a dose of 0.5 milligrams per kg body weight over 45 minutes by IV infusion with the use of a syringe pump, and the patient was observed for 2 hours after the administration of ketamine. Again, the regimen was similar to ECT, thrice weekly. And they found that there was I've summarized the results here. Efficacy-wise, ketamine was comparable to ECT in depressive disorder. Both ECT and ketamine were equally effective in decreasing suicidality, except that the response happened much faster with ECT as compared to ketamine. There's no significant differences in terms of tolerability or the impact on cognitive function. So this is submitted for publication, and I think we should be able to have this paper out shortly. So I'd like to thank the authors for letting me use this data for this presentation. A study that I've been associated with looking at the role of yoga in depression, which is coupled with the neurobiological investigation of the efficacy of yoga. So where we take patients, the idea was to take 100 subjects with depression and randomize them to treatment as usual plus yoga. This is a waitlisted group who can be offered yoga after the study period of 3 months. The investigations that we did were cardiac autonomic function tests, both at baseline and at treatment endpoint, cortical inhibition using TMS, functional magnetic resonance imaging, including facial emotion recognition, using a tool that has been validated for the Indian population, and blood biomarkers. So what we found was that the group of subjects who were given yoga as an add-on treatment had a greater or a faster drop in the Hamilton Depression Rating Scale scores, and they reached remission much earlier as compared to the treatment as usual group. So this is one of the things that we found interesting, and we're probably going to make a recommendation in the paper that, where possible, all of them can be offered yoga as a additional add-on treatment to standard antidepressant therapy to enhance the efficacy of it could have a beneficial effect in that it could enhance response rates and maybe reduce the number of people who would go on to become treatment resistant. Of course, this is not done in subjects with treatment resistance, so the results have to be taken with a pinch of salt. Yeah, the last few slides, points to ponder. I was calling this these slides the take-home message, but then once I started giving webinars, I realized that most of the people are already at home, so it's not a good title to use. So points to ponder, if you would please. So I think COVID-19 has made it necessary for us to rethink psychiatry practice. Hanish just alluded to it. I'm just going to add on to what Hanish has just said. So we need to rethink the way we're going to offer psychiatry services. There's going to be a lot of community-based psychiatry practice in future as compared to hospital-based services that we have been offering all along. In-person versus teleconsultation, I think that shift is likely to happen. A lot of people are going to opt for teleconsultation as compared to in-person consultation, especially till the measures for physical distancing and overcrowding are in place. Triaging, I think, will become the new normal for psychiatry practice, particularly this can be particularly concerning. For example, if I have to admit a patient right now, we're looking at whether the patient has suicidal risk or whether there is risk of threat to life before we admit the patient. We're not admitting patients like we used to for psychotherapy or for some other rehabilitation related treatment. So triaging is probably likely to be the new normal for psychiatry practice for some more time to come. Again, triaging will be required for patients, in terms of who requires inpatient care, who requires treatment with a specialist and who doesn't. So I think it's going to alter psychiatry practice, and in turn is going to have an impact on depression and difficult to treat depression in the times to come. So that's what I was trying to say when I meant that difficult to treat depression we're going to move towards, probably, a period where any depression is difficult to treat because of all the reasons that I've enumerated above. We're also already seeing a lot of scaling down the services in terms of the treatments that we're offering for difficult to treat depression. Like, for example, we're only offering ECT now. The number of ECT sessions that we've administered in the last 2 months is probably only about 18 patients as compared to 143 patients over a 5-month period. So the number of patients who are receiving ECT has come down. We've stopped TMS and TDCS services. We have stopped all ketamine treatment. All the yoga therapy services have been stopped. Only tele-yoga, which is a general yoga, not really the yoga module for depression or anxiety, is being administered. So I'm not sure when some of these services will resume, which is essential for treating depression. Objective assessments, which require a lot of physician-patient interaction and time spent with the patient, may need to be reassessed, and we need to probably move towards more subjective reporting and online forms that the patient can fill, and we'll have to take these assessment results with a pinch of salt. And of course, the whole lot of battery of investigations that we've been talking about in terms of the vitamin B12 levels or some of the other investigations that Hanish mentioned, that would be essential for us to assess treatment-resistant depression. How easy is it going to be for us to do these investigations in the near future? So these are some of the points that we need to ponder about as we talk about difficult to treat depression or treatment-resistant depression. So I think that brings me to the end of my presentation. Thank you so much for your attention.
Thank you very much, Murli. Hanish gave us the framework. Murli delved deep into it in terms of looking at specific treatment options. I'm happy to tell you, ladies and gentlemen, that we've crossed half a century in terms of people who are watching this, listening to this webinar today. Also, the questions have started coming. Thank you for that presentation, Murli. Madhu, over to you now, and keep the questions coming as we listen to Madhu, and then we go into the last part of the webinar where we will address all the issues that you're putting as questions on the chat. Over to you, Madhu.
Thank you, Shekhar. Well, as I suspected correctly, I think most of the technicalities of difficult to treat depression has been covered by Hamish and Murli. So mine is a different perspective, more of a socio-cultural perspective related to Sri Lanka regarding what we might call difficult to treat depression. I hope everybody can see my screen. Yeah, thank you. Okay. So I do not have any conflicts of interest to share. Just a little bit of an orientation to the healthcare system of Sri Lanka. As you know, it's a small country just to the south of India in the Indian Ocean. We are a very small country with a small population of just 21 million. But we have really good statistics. The adult literacy rate is around 96%, and maternal mortality is around 39 per 100,000 live births, which is one of the, the lowest in the region. In context of that, I would like to share with you a very simplified version of the healthcare system in Sri Lanka. So through the government, the Department of Health, we have free healthcare, similar to, I suppose, in a few other countries. We have a very good primary healthcare system where each district is divided into manageable chunks, and one medical officer of health is responsible for the primary care of this is basically preventive aspects of around, let's say, 10,000 to 20,000 population. And that area is also further divided into smaller chunks, and a primary healthcare worker called the public health midwife, similar to a nurse, is responsible for the families. And this is a well-functioning system where the PHM, as we call her, is actually in touch with all the females in the area who of the childbearing age, and all children below 18 years of age. For example, she will provide all the immunization services, all maternity services, child welfare, nutrition. So it's a very well-functioning system. There's a secondary and the tertiary system where the hospitals, based in hospitals, are also provided free of charge. There's a separate system of private sector where there are the hospitals, which are few in number, not many. And then, of course, the GP practices, which are most often run by doctors who are working outside their usual working hours in the hospitals. I think this is important to understand, because to see how patients can access mental health care in Sri Lanka. If you look at mental health service provision, one of the best things that I can see in our system is that a person with a mental illness or any psychological issue could actually self-refer themselves to a psychiatrist. So even the place where I work in, which is the largest tertiary care hospital in Sri Lanka, the multidisciplinary teams led by a psychiatrist, we do accept walk-ins. So as soon as you walk in, you would be triaged by basically a healthcare worker or a doctor, and it would be decided whether to see the person and offer help then and there, or see as an outpatient in a clinic, or be referred outside to another healthcare system, another hospital or a GP practice. We get referrals from the hospital outpatient department if the patient goes there. We do receive referrals from other medical and other surgical units, other subspecialties. We get referrals from the primary healthcare system, the medical officer of health that I explained. For example, the midwife would actually do Edinburgh postnatal depression scale 30 days postpartum, and if the score is high, we get those referrals directly from the primary system. And of course, we get referrals from the GP. So this is how our mental health care provision is run. And from the multidisciplinary team, the outreach teams for community service is provided. So a little bit about rates of depression. I used data from several studies which have been carried out in Sri Lanka. You will see that some of the numbers are much less than in other countries. For example, this 6.6%. However, among older adults, the rates are fairly comparable to other countries. So because I don't have data on how many out of the total population suffering from depression would maybe defined as difficult to treat depression, I'm assuming that we have the similar rates. I like this concept of changing over to difficult to treat depression from treatment-resistant depression. Treatment-resistant depression actually has a lot of emphasis on treatment, medications. And on the other hand, as we go along, you will see for the Sri Lankan socio-cultural background, difficult to treat depression emphasizing on the person and the environment and the family is a more acceptable model for us. And that actually emphasizes the person and would point out that help is to be provided to the person rather than looking at the treatment per se. So looking at the challenges in managing difficult to treat depression in Sri Lanka, what are I tried to look at the different factors which might determine a depression as being difficult to treat, as outlined in the publication in the Journal of Affective Disorders. And I believe that some of these factors are not only applicable to difficult to treat depression, it's applicable to any mental health problem, any illness in Sri Lanka. And these factors are the ones which might actually make depression difficult to treat in our socio-cultural context. Stigma related to mental illness. In Sri Lanka, mental illness is seen as a very stigmatizing condition. So one of the first questions that would be asked by a psychiatrist, which I have answered 1,000 times, when a young woman or a young man comes with mental illness from parents, is that would my son or my daughter be able to get married? And while emphasizing the fact that, yes, of course, he or she would get better, would be able to lead a normal life, would be able to get married. On the other hand, we have to emphasize the fact that it would be best if the partner knows that you are taking treatment for depression and maybe for quite some more time. So people tend to not present for treatment and maybe sometimes keep this as a secret from their partners, from the rest of the family members. This poses a lot of difficulties because once they get married, they tend to stop medications and then again present with relapses and altering the prognosis as you go along. The biological model versus spiritual model is something that we struggle with all the time. The allopathic medicine focuses more on the biological model, depression as a biological condition. So when we are explaining, we explain that, depression, there could be some alteration in some of the chemicals in minute, concentrations in your brain. Whereas the common model, which is closer to the general public, closer to the Sri Lankan people, is the spiritual model, which is more acceptable to the patients who present. So the local healers and certain other religious practices, that spiritual model is actually more closer to them. Therefore, again, there is a clash between the mental health service provision and the patient's values and beliefs. And this is something I usually try to come to some understanding when we are dealing with patients. So if they want to do some rituals, if they want to understand this in terms of malevolent spirits or some malevolent positioning of planets, I think it is important to understand their explanations. And sometimes I do say, if it is not expensive and if it brings you some reassurance, it is okay to go through some of these rituals while taking the medication and while maintaining a therapeutic connection. Cultural and religious values and explanations for symptoms and illness is something again that we find difficulties in handling patients. So I'll give you just one example. From the beginning, it was a difficult to treat depression because eventually we found out that this young woman was actually presenting with bipolar depression, and then her relapse pattern was the relapse signature was such that with any conflict, with a stressor, she would go into a severe depression. And when she presented a few months ago to me, I was exploring for any possible stressors, but nobody was coming out. She was not coming out with any stressors. Her family was not coming out with any stressors. And the explanation was she was about to get married. She was legally married, but in Sri Lanka, till the marriage ceremony has taken place, people usually do not live together. So everything was going fine with her husband, with her family. There was no stress. And we were struggling with managing her symptoms. She was not getting better. Lots of therapeutic options, medications were tried. And then electroconvulsive therapy was tried. 1.5 months into treatment, well, I suppose that at that point we were calling it treatment-resistant depression. And then she was getting better, and I kept on exploring, and I found out that the conflict was that before she could have the marriage ceremony, that against her, general beliefs, she had sex with her husband, and this was actually creating a lot of conflict in her, which she couldn't reveal to the family. And well, if I didn't elicit that, I feel that, this would have gone on for around another 2-3 months. And we would have been looking at treatment resistance, what are the factors causing treatment resistance, whereas we wouldn't have explored for any psychosocial stressors. Now, for people who wouldn't be very familiar with the religious and cultural values of Sri Lanka, this is an interesting aspect. How people see certain symptoms of depression or certain affect states. So in Buddhism and also in Hinduism, certain effects arising from life events such as loss, bereavement, suffering from a terminal illness, we do not see that as depression. And that actually, even though I've given it under the challenges first, that can actually work very well in helping a person. If you look at this monograph on depression, Buddhism, and the work of culture by the famous world-renowned Sri Lankan anthropologist, Gananath Obesekara, you will see that, he describes one case where one of his closest friends who was a clinical psychologist, was amazed at how, during his trip to Sri Lanka, found that another friend of Obesekara was a classic case of depression, whereas nobody around him, or of his family saw that as depression. It was simply that he was tired and was seeing the impermanence of everything around him, and that led him to yoga, meditation, and retreats. Whereas in a Western culture, which it could have been actually diagnosed as depression. Now this can work positively for most of the time. On the other hand, I've seen a few times where it works negatively, where hopelessness is actually worsened by acceptance that this is my karma, that I would have done some bad deed in the past, and this is why I deserve it. I've seen that being linked with hopelessness. So all these socio-cultural factors lead to poor adherence to medications, and that is one of the major factors which causes difficulties for us in Sri Lanka. What are the treatment and service related factors? We have a restricted choice of medicines and treatments in the free healthcare system in the government, and to a certain extent in the rest of the private sector also. For example, we don't have certain medications available in the government sector, and we don't have, like NIMHANS, we don't have Rtms, TBS, any of these treatment methods. So therefore, certain Western treatment algorithms are not very user-friendly for us. For example, at the time study came, that was one of the difficulties that we had. We didn't have citalopram in the government sector at that time, and we didn't have Bupropion, and we didn't have enough psychotherapists to give CBT, and so we were finding it difficult to, correlate study findings to our treatment practices. Our community mental health services are still developing. Our mental health services are mainly provided through the secondary and tertiary care units, and the community mental health teams are sub-teams from those units which go out for outreach clinics and various other community, for provision of community mental health care. So therefore, we find that sometimes prophylactic care and also follow-up might not be as strong as desired. Well, brain drain is one of the most important aspects for Sri Lanka, and as you know, a large proportion of psychiatrists in UK and Australia are actually qualified in Sri Lanka. So therefore, less number of psychiatrists, and we find that we have less time to do formal psychotherapy for patients. So in fact, I can only take around 2 to 5 patients at a time for psychotherapy, because otherwise with my patient load, it's difficult for me to commit to psychotherapy. And that is the reality in Sri Lanka, even though we try our best. And this is the same for other centers also. We have around 200 psychiatrists in the country, and so that's becoming less, even with with people migrating. What are our strengths? The treatment and service related factors that I see are that the number of barriers in reaching tertiary care is very much less. Therefore, the risk of somebody with residual symptoms falling through the cracks of the system and just remaining in primary care or secondary care is very much less in Sri Lanka. So they would actually be able to access care very soon, and the treatment, the duration taken to reach that level of care is very much less. And our acceptance and use of ECT is good. So the acceptance by patients of ECT and the use of ECT, even as written by Hamish, for us, ECT is not a stepwise progression to ECT. We usually use ECT as a first line treatment coupled with pharmacotherapy. And that has actually given us very good response rates. So our response rates are somewhere around 45 to around 80% in various types of depression. Patient and socio-cultural factors, our society is more collectivistic rather than individualistic. So family participation in treatment, as lies in the management, is the rule rather than the exception. So families participate in medication supervision, in helping as co-therapists in behavioral activation, and even in that example that I gave of the young woman who was having conflicts, because we were working with the family at that time, I could open up a dialogue between her and her mother, and that actually helped to come to terms with what has happened to her. And her values and beliefs. And also that what I discussed about Buddhism and Hinduism, that the religious and cultural beliefs, so sometimes it is encouraging even to live with residual symptoms as in a recovery model, such as the one that we use in schizophrenia. So it's actually not treatment resistance, but how to optimize your functioning and how to sometimes live with some residual symptoms. The future, well, our numbers, we are not aware of a number. So that's one of the studies that we are carrying on at the moment with the rest of the NEESAMA group. And what are the treatment strategies which would be optimal to the healthcare system in Sri Lanka according to our logistics, according to our services, according to our resources, and hopefully might lead to a guideline. Novel treatment strategies are actually being tried out. In our unit, we are hoping to start a study on the use of IV ketamine. And of course, we need to strengthen our community-based services and in ensuring adherence and follow-up. With regard to COVID, of course, my fear is that because of the reduction in, we are discouraging patients to come into the hospital, even though we are contacting people over the phone. And teleconferencing is not something which is accessible to a large number of people, of course, only to a certain percentage of people. My worry is that people with residual symptoms, people with poor response will actually be lost to the healthcare system with this COVID pandemic. And of course, the new norm would actually be distancing and, encouraging people to use teleconferencing and online methods of being in touch with the patient. This is something very difficult for Sri Lankans, for South Asians. Even social distancing is very difficult. I find that, when I'm seeing a patient keeping a patient 2 meters away with all the masks and everything in place, they still feel a little bit bad about talking with the doctor from a far away distance. They try to, pull the chair and, come a little bit forward. And because, that intimacy with the doctor is important for the therapeutic relationship for them. So some of these things would have long-standing implications on management of depression in Sri Lanka. Thank you.
Thank you very much, Madhu. This is remarkable. If you look at the three presentations, how Hamish started with a conceptual model of assessing, diagnosing, looking at comorbidity, and looking at all the factors that contribute to what is a difficult to treat depression. Murli delved into it to look at some of the modern treatments and then spoke about some elements which are specific to the kind of experiments that are being done here in terms of yoga. And Madhu completed the triangulation by really looking at systemic issues, how systems function to actually support this kind of a clinical population, and how the cultural elements of a particular country or a particular community or region also make a difference in the kind of treatments that would actually alleviate this condition. So it's a beautiful triangulation that has been done in this seminar. So the clinical concept and model, modern treatments, and core clinical intervention approaches, and systems and culture, and how therefore we can use this combination to really address the conundrum of difficult to treat depression. We have several questions. I'm going to come to Hamish first. This question comes from Dr. Chavi, who actually works in Northumberland. The question, Hamish, is this, that as far as secondary care services are concerned, what would be the best treatment option for difficult to treat depression when a person with this condition has ongoing stressors, physical morbidity, substance abuse, or a combination of all three? And what is the best way to make an alliance with such a person to explain to these people how these conditions feed into the depression? Hamish?
That was a nice, simple, easy question to answer. I think I'd probably start off by saying that, the way there is no single treatment that you would say, oh, well, that's the one to choose for this particular individual. Rather, it would be saying we need to look at all of the different factors that are going on with this particular individual. If they've got comorbid physical health problems, are those being managed okay? Do we need to speak with our physical medicine colleagues, any general practitioner that might be working with the patient on those particular issues to try and optimize treatment? Because it's about trying to optimize treatment of all of the various different elements that are potentially contributing to the patient's depression. And then in terms of choosing the actual treatment for the depression, I guess I would always start by doing a very thorough review of the person's treatment history, see what sort of hints and tips we might be able to get from that. Is there evidence of some response, but maybe partial response to a particular group of medications? And maybe if we go back to them, look for one that may be slightly more efficacious, or maybe go back and have a look at higher doses, for example. Or do we need to look for a completely different class of treatment if we're thinking pharmacotherapy? Do we need to be thinking about neurostimulatory treatments or psychotherapies as well? So it is really trying to be holistic. So I think the question is pretty challenging, to put it mildly. I think one of the other elements of the question was around how do you engage with the patient, and think about, how do you help them understand that all of these things may be relevant? I think in my experience, I don't think that's particularly difficult. Because I think if you say to a person, look, you've got pretty horrendous asthma, and that asthma isn't particularly well controlled at the moment. How do you tend to feel when your asthma is less well controlled than when it's well controlled? And most people go, well, actually, I feel frightened, worried, anxious when it's less well controlled, and my depression gets worse. I think it's, you know, when a patient says that, you go, well, okay. So if we're going to make grounds with treating your depression, we need to make sure your asthma is well controlled as well. So I usually don't find it that difficult to be able to help patients see those links. I think the key is really, it just takes time. And it does require some exploration with the patient about those issues. But I don't think they're actually that difficult to see the links.
Thank you very much for that, Hanish. Dr. Chavi continues to put a question which I would like both you, Hanish, and Murli also to respond. This is actually about the use of Bupropion, and Chavi says that she had experience of using Bupropion in India, but not in secondary services in the UK. And is it all right to use them in secondary services in the UK? I will let Hamish go first, and then Murli can come in.
Okay, so Bupropion is not licensed for the treatment of depression in the UK. It's only available as a product licensed for use in smoking cessation in the UK. But what we do know is there is a good, strong evidence base for its use in depression. So it is possible to use it in the UK. Any doctor can prescribe anything. But it is up to them to be able to justify what it is that they're actually prescribing, potentially in court, if they were sued about what they had actually done ultimately. However, while technically any doctor can prescribe anything, usually there are local regulations and formularies and so on that try and help guide doctors as to what they can prescribe. And Bupropion may well not be on the local formulary as an antidepressant. And then it's a case of actually following whatever procedure there is locally to actually make an application to actually use it. We use Bupropion really quite frequently in our clinical service. I do find it a really useful additional treatment because I think its pharmacological mechanism of action is very different to many of our other antidepressants. And I think its effect profile in terms of symptoms is also very different. I talked about symptoms that can be associated with poor quality of life, including things like tiredness and fatigue. And I think that a more pro-dopaminergic treatment like Bupropion can work absolute wonders in that sort of situation. You know, because it is so rarely used in the UK, most patients who come to us in our specialist services have never had it. And switching somebody from an SSRI to Bupropion can be fantastically helpful for some individuals, or sometimes adding Bupropion in to an SSRI as well. So we do both of those things.
Murli, any thoughts from you?
Yeah, I think Hamish has enumerated most of the reasons why we would also prescribe Bupropion here. Our experience has been quite similar, but in terms of using Bupropion to treat depression, it's usually the third or the fourth line drug. And a lot of times it's dictated by the symptom profile of the patient. The presence of atypical symptoms of depression, for example, the clinician would choose Bupropion earlier than what they would choose otherwise. So in terms of the clinical symptoms, also Bupropion, the choice of Bupropion is dictated by the clinical symptoms. Another indication where we tend to use Bupropion a little bit more would be bipolar depression, probably because of the lesser risk of switch with Bupropion than with the other standard SSRIs or tricyclic antidepressant drugs. So we find a lot of clinicians using Bupropion in patients with a depressive episode occurring in the course of bipolar disorder. So we have recently completed a multi-center study where we looked at antidepressant plus mood stabilizer as maintenance treatment for bipolar depression. So the Bupropion was one of the drugs that we tested. So escitalopram was the other one. So the open phase, we had patients taking both escitalopram or Bupropion, depending upon the clinician's choice, in discussion with the patient, of course. And in the double-blind phase, we had patients with either of these drugs being randomized to their respective placebos. It was either bupropion versus bupropion placebo or escitalopram versus escitalopram placebo. From what we have in terms of the results from the open label study, most of the patients who were prescribed bupropion actually had good improvement and remitted within 3 months of starting of bupropion in patients who had bipolar depression. So the results are quite encouraging. There were not too many people who experienced switch, and the switch rates were definitely lower with bupropion than what we saw with escitalopram. So in unipolar depression, probably symptoms of atypical depression, in bipolar depression. So if we do use it in bipolar depression, how long do we continue to use bupropion? So these are some of the decisions that the clinician would have to take. Thank you.
There is a conceptual question. Thank you very much for that, to clarify the whole issue on bupropion. There's a conceptual question which actually Adi raised as Murli, you brought up this concept of pseudo-resistance. So perhaps you could enlighten us about what pseudo-resistance is and what would be the range and the structure of this concept. And if Hanish and Madhu have something to say, I would very much invite them also to contribute.
Sure. So the pseudo-resistance is something that we tend to see a fair bit in our clinical practice, and there's a lot of literature also to support that. So the idea is that before we decide somebody is actually resistant to treatment, we need to examine all factors that could be contributing to non-response. And a lot of times we find that we have not checked for, like for example, to give you an example, let's say we are prescribing, say, a quetiapine for bipolar depression. You would find that clinicians may have prescribed 100 milligrams or 150 milligrams. They wouldn't have checked for, the pill compliance, pill count may not have been done. The drug compliance may not have been tested for. So the impression that a clinician would make in this scenario that the patient is not responding to treatment would be rather erroneous. So if you look at guidelines, they'll say that, okay, bipolar depression, you would need to give at least 300 milligrams of quetiapine. So build up the dose. Give it for a period of about 6 to 8 weeks, which is the adequate duration of treatment. Ensure that the drug compliance is there, preferably with a blood level testing if possible, or with a pill counting method, the most simplest ways of ensuring treatment adherence. And once all these are, and then also we need to look at whether there's been a drug interaction between the drug that we prescribed and maybe another medical drug that the patient is already taking. So the clinician would have to have some kind of an algorithm to rule out most possible possible causes why the patient is not responding to a particular treatment before we say that the patient has become resistant to treatment. So pseudo-resistance is all these conditions that could make it appear that the patient is resistant to treatment, but actually it requires some degree of normalization of some of the other treatment practices that are already there. So that is something that we teach our students a lot now, so before you decide that somebody is treatment resistant. Because the tendency, particularly with, say, a condition like schizophrenia, the tendency to run towards clozapine is a lot higher if we've not defined resistance, very rigorously. So, over to Hanish.
Hamish, any thoughts on this?
Yeah. Whoops. Yes. I think it's a really important point, and I think certainly in UK practice, I don't think it's one that's particularly well looked at. There is big national variation in therapeutic drug monitoring across Europe. So in the UK, therapeutic drug monitoring is very rarely done of antidepressants, whereas in German-speaking countries, it is very frequently done. It's the routine, it's the norm. And it's unclear as to why that is the case. Personally, I don't think there's lots of good evidence around relationship between plasma level and response. So therapeutic drug monitoring as done in German-speaking countries, I'm not sure there is good evidence for it. However, therapeutic drug monitoring to ensure that it is true resistance as opposed to pseudo-resistance is potentially important. In epilepsy, patients would never be described as being treatment-resistant, having treatment-resistant epilepsy until you'd actually demonstrated non-response to a medication with adequate blood levels. So, there is a bit of an issue. If we try and actually get blood levels of many of the antidepressants, we'll be told they're not available, or it's too expensive, or we shouldn't be doing it, it's not routine. So I think there's a big issue around this particular one, and I don't think there's an easy one, particularly when you're assessing past treatments that the patient's no longer on, because you can't even do the pill count then.
Madhu, any thoughts on this?
Shekhar, one of my experiences is that, with optimal blood levels and, optimal treatment trials, something to look for are the psychological aspects. If you find that, the patients are still not getting better. So avoidance, ongoing conflicts, personality issues, that would always help looking at non-medication aspects also.
Thank you very much. There is a question, Murli, from Dr. Tiwari, which is about this 5% lifetime prevalence of depression in the National Mental Health Survey. And his question is, isn't that an underestimation? There's a related question, which you could take, and Hamish as well, which is the treatment gap when you presented was mentioned as 85% in one place, and then for bipolar disorder it's 70%. Now, given there's a delayed diagnosis from the onset of bipolar disorder to diagnosis, sometimes there's a gap of 10 years, isn't there the treatment gap in bipolar disorder likely to be more than 70%? So isn't 5% lifetime prevalence of depression an underestimation? And wouldn't treatment gap for bipolar disorder be more? Murli?
Yes, sir. So thank you. Both are very important questions, very useful questions. It is an underestimation. There's no doubt about it. The reason for the underestimation is something that we had been warning about all along when the study was conducted. It's that they only used mini version 6 to screen the population. So had we used a more structured assessment for depression, it's likely that we may have picked up more. So that's something that we were, it was a trade-off between epidemiologists and psychiatrists as to what is the best instrument that you can use for screening. Since we were able to get Sheehan on board and Mini6 was translated and back translated in different Indian languages, it was the easiest thing to do. But if you look at the rates of psychosis per se in the NMHS survey, it is very, very low. The reason why I have always been very vocal about the inadequacy of Mini to get accurate estimates is that to a great extent, the National Mental Health Survey is going to dictate government policy towards psychosis and depression and bipolar disorder. And by underreporting it, we are going to make our lives more difficult. But like I said, it was a trade-off between the epidemiologist and the psychiatrist. So we were happy with what we got. Yes, 5.4% lifetime prevalence is an underreporting, and I agree with that. In terms of bipolar disorder per se, and I do agree with your point that there is a time lag between the onset of illness and the actual diagnosis of bipolar disorder. Of course, one may argue that in India, the statistics are different, and most of the patients in India, there are studies from 3 or 4 different centers, including us, including one that I have published in the Journal of Affective Disorders, where we find that majority of the patients have an onset with a manic episode. And the course of bipolar disorder in India tends to run a predominantly manic course. So once someone has a manic episode, then the diagnosis of bipolar disorder is no longer in doubt. The issue is more when the onset of bipolar disorder happens with a depressive episode. But studies across the country have shown that yes, we tend to have the manic episode occurring fairly early, and a manic episode is more likely to bring the patient into the hospital and in contact with mental health services than probably a depressive episode or a mild depressive episode. So yes, while the treatment gap as reported by the mental health survey may be a little less than what it actually is, it may not be very far away from the mark.
Hamish, any thoughts on this?
No, I don't really have anything to add to what Murali's just said. I think it's fascinating that there is this difference between the presentation of bipolar in European countries and India, for example. Why there should be such a higher rate of first episode being mania in India than it is in the UK. There's bound to be a bigger gap, delay for diagnosis in the UK. There has to be. if you have 2-3 episodes of depression before you have your first episode of mania, you cannot be diagnosed as having bipolar until you've had that episode of mania.
Thank you very much, Hamish. There's a question from Jackie and Elliot. Madhu, I would like you to address this, but I'd of course like the other panelists also did, because it's very important. What does the panel think about the move towards more remote technology use after the pandemic? Because the importance of the therapeutic relationship and the ability to assess non-verbal communication in patients experiencing distress. Jackie's worry is that we will lose the power of the consultation, such as the idea that the doctor-patient relationship is part of the cure, a lot of the cultural stuff that you spoke about, or the laying on of hands aspect of care would be lost. Adi also actually added to this, saying further to this question, the issue of whether virtual or remote monitoring affects need for therapeutic optimism, and how do we reconcile this? Madhu, your responses?
This is something I think we've been struggling with for the last 2-3 months. And in the beginning, it was very difficult. For example, certain patients you had to manage, you had to speak over the phone and, assist them. If they were not accessing any, a smartphone or any video conferencing facility. And we were struggling with how these assessments could be done. We were struggling with whether these assessments were really valid, whether we were making the correct decisions. And eventually, I think it was a compromise between, feeling safe in certain situations with patients and, knowing that, maybe this was possibly correct. And we used sometimes collaterals given by other family members also in this process. And that was very useful when you obtain information from others regarding their daily functioning and everything. But I think as a psychiatrist, I felt very uncomfortable at certain times assessing patients over the phone. And sometimes I had to get them down, even though, the hospitals were discouraging patients coming into the hospital. We had to get down certain people and, see them physically. And I think it's important you make that distinction. The person who would be okay to be managed via teleconferencing and the person who would not be okay. And at that subtle difference, it's very difficult. It's touch and go. I mean, you might make a wrong judgment, but I think always having the option of getting down the person and, seeing the person face to face is reassuring. On the other hand, I think teleconferencing is now there to stay. I don't think, it's not going to go away. That is not something which was accessible to us in the beginning in our unit, and now we have got used to it. So therefore, I think we have to, the newest terminology in COVID is getting used to the new normal. So I think we will, have to accept that it is the new normal while keeping, the therapeutic relationship, the physical assessments also as the possibility.
It's interestingly, Farzana Islam from Bangladesh makes a comment that a lot of the patients there of depression, depressions presumably, don't like to take, cannot take medicines because of socioeconomic reasons. And therefore, making alternative treatments like yoga, meditation, and psychotherapy, and making access to them would be a good option. But given the current scenario and the question that has been raised by Jackie, and what Adi has also said about the option of the virtual option, what is the kind of response, Murli, and then followed by Hanish? Murli, your response?
Regarding telepsychotherapy, telemedicine-based practice. Yeah. So I have 2 points to make, actually. One is in terms of teleconsultation that we may have to provide to patients. Again, and the second one is about telepsychotherapy, and I have kind of mixed feelings about the use of technology. So what we need to do is to find a middle. Why I say mixed feelings is, one is, as Jackie has pointed out, the physician-patient contact is of utmost importance, particularly in a discipline like ours, where we need to spend a lot of time with the patient, and the therapeutic relationship is very important. The second thing is that the use of technology makes the access to a specialist more easy for the patient. So it has to be a trade-off between accessibility as well as the kind of good care that is possible with technology. So what we are recommending here as a part of our telemedicine practice guidelines is that the first consultation or the first few consultations should happen in person, and the subsequent follow-up consultations should be moved over to a medicine kind of practice. So the clinician, in discussion with the patient, can take the decision saying that, okay, we've spent 2 or 3 sessions in in-person consultation. Can we stagger your in-person visits? Would you like to do a telemedicine-based follow-up in the interim period? So that's as far as teleconsultation goes. In terms of telepsychotherapy, I've been involved right now in preparing a framework for telepsychotherapy, because the demand for continuing therapy has increased both from the patients and from clients and from the students, because most of them have not been able to contact the therapist of late. So again, here we need to have some kind of a minimum criteria about who can be eligible for telepsychotherapy, what kind of patients are, also in terms of the experience. So we are also involved in training our students, our residents, in the various techniques of psychotherapy. So maybe we should say that, okay, for the first 6 months or so, they should not practice telepsychotherapy. First, learn the nuances of psychotherapy, learn about, my guru is watching, my guru, Dr. Shekhar Sheshadri, he taught me psychotherapy, is watching me. So I have to say this here, that we have to train our residents in the skills, the psychotherapy skills. And that can only happen when face-to-face therapy sessions are conducted. So the first 6 months or first 1 year, the people who are taking up psychotherapy practice should not do telepsychotherapy. Once the supervisors and once the clinicians are confident that they can switch to a telemedicine form of therapy, then I think they should, in discussion with the patients, move over to the telepsychotherapy kind of a practice. Even there, I would suggest that the first few sessions should be face-to-face. And maybe by mutual consent, the clinician and the client can decide that, yes, we can move over to telepsychotherapy kind of a practice. The reason why I'm advocating this also is that right now psychotherapy becomes geographically restricted. The patient who is very close to the therapist is the one who's likely to come regularly for therapy. The longer the distance between the client and the therapist, the less the greater the chance that they're going to drop out of therapy. Whereas with the telepsychotherapy, geography is no longer an issue. And then the therapy sessions are more like, the dropouts are probably going to come down. I'm being optimistic, but dropouts are probably going to come down. Thank you.
Your thoughts on this, Hanish? Thank you, Murli.
I don't think I can really add to Murali's wise words there, because it is that trade-off, isn't it? I think face-to-face is preferable, but you've got the disadvantages with regard to accessibility and geography. And I definitely agree with this whole business about early consultations being face-to-face and then potentially moving. In the last couple of months, I've had no problems, or no major problems. I probably couldn't say no problem. No major problems doing remote consultations with patients that I know very well. But doing first consultations, that's a different matter. And I definitely feel more uncomfortable with that.
The last 2 questions, one is for Hanish and one for Madhu. Hanish, the question for you is again from Dr. Chavi. The question is, how useful is the domain model for treatment of the difficult to treat depression? The specific question is, when you look at neurotransmitters and specific drugs for specific symptoms, so this whole domain model, any comments on that, Hanish?
Yeah, I suppose I have quite a strong view on that. I wish it was true, but I don't believe it. I think that, I spent all my early career sort of working on neurotransmitters and specific serotonergic function. And, the idea that we might have drugs like SSRIs that could specifically target serotonergic neurotransmission, as opposed to something like Bupropion we talked about earlier on, that might be able to specifically target dopaminergic function. The problem is the evidence base to support the notion that you can look at a patient's symptoms and then work out which drug they should have is absolutely wafer thin. So really there's little evidence to support you doing that. So do I never do that? Well, yes, I still do try and do it. And I still do try and say, well, you know, but this is more sort of further down the line. If it's a first line treatment, I think I would still just go for an SSRI. But further down the line, if there's been non-response and the person has got atypical symptoms, then I might be saying, well, let's think about an MAOI because they've got some evidence base in atypical depression. Or should we be thinking about something like bupropion for the person who has got a lot of daytime fatigue and anergia? So I do tend to fall into that trap of doing it. Whether it works just because it's just anecdote and actually there's not really good evidence supported, I don't know. So I think we just need to be cautious. I think we need to be very cautious into falling into the trap that we're cleverer than we actually are.
Thank you very much, Hamish. Madhu, the last question, it's a complex question, and this relates to the point that Hamish made in his presentation about why difficult to treat depression is an important issue to address, not merely from the perspective of morbidity, but from the perspective of mortality, and he made specific reference to the phenomenon of suicide. So the question basically is this: Sri Lanka, as you know, has among the highest rates of suicide internationally, if you look at figures. And where do you reconcile this phenomena with the difficult to treat depression, particularly with young populations in the context of adverse childhood experiences, and those young people with depression who have depression in the context of unipolar disorder or bipolar disorder, and where the rates of self-harm and suicide are significantly high. And even from a cultural perspective, how do you sort of put a frame to understanding this, and what would be some of your thoughts and experiences on this phenomenon?
Thank you, Shekhar. I think there's one study from psychological autopsy study, which is quite old now, from Sri Lanka, which has found out that, you know, people who committed suicide were more likely to be depressed and having comorbidity, who had, you know, alcohol dependence. That was the findings. However, now we find that currently our the patterns are becoming different. This is one of the papers that I've been working on recently. So our suicide rates have come down from 1996 to around, so 1996 it was around 46 per 100,000, and then in 2018 it's somewhere around 14 per 100,000. And we find that previously it was mostly organophosphate poisoning, and now the rates are slightly getting higher for hanging. So this is an interesting phenomenon. We find that the rates are higher for elderly males, which is becoming sort of similar to the other Western countries, where the suicide rates are higher in older adult males. However, to understand the on the other hand, our rates for young females is also quite high. And what we see in our daily practice, we see a large number of young females coming with deliberate self-harm. And this has to be, I think, even though this is, you know, a large project to, you know, understand the socio-cultural factors around this, the population that we see mostly are young females who are employed outside home from very rural areas, who have come to cities like Colombo, to the free trade zones, what they call free trade zones, where they have a lot of factories producing for international market. And they are, you know, staying in boarding places, far away from home, facing a lot of socioeconomic disadvantages, relationship difficulties. And what we see is the suicide culture among, you know, these young females. So that resolution of conflicts and, you know, problem solving, self-harm is one thing that they resort to in conflict resolution. So my guess is that because our self-harm rates are going up, my guess is that this accidental, so where they do not intend to commit suicide but use it out of distress, they end up in committing suicide, and that is why the rates are higher in younger females. And the depressed elderly male population actually might use more lethal methods, and that is why the hanging rates are actually going up. So that's my understanding of that.
Thank you, Madhu, for that clarification. So, difficult to treat depression, ladies and gentlemen, 3 wonderful views. Remind you again of Hanish's Journal of Affective Disorders 2020. It's a wonderful piece on the conceptual model of how to assess and understand difficult to treat. How Murli has taken us through the extraordinary amount of work that NIMHANS has done in non-invasive brain stimulation and so on. And the wonderful stuff that Madhu has shared with us about how systems respond to people and the role that culture has to play in. A lovely triangulation of what we have present. Just to remind you all that NEESAMA presents its 3rd webinar on the 20th on the intolerance of uncertainty. It is at 9 a.m. UK time, that's 1:30 India time. Those of you, I believe that many people have already blocked their places, but please do.
Sorry, Shekhar, I'll rudely interrupt there. The webinar is sold out. In fact, the waiting list is also sold out.
I see. That's wonderful. That's wonderful. Also to let you know that those of you who would like to have the continuing professional development CPD certificates for this, please do drop in an email to Catherine Parker at Catherine, KATHRYN.Parker, PARKER, at cntw.nhs.uk. That's Catherine.Parker at cntw.nhs.uk. Those of you who would like a CPW certificate. Thank you, Hanish. Thank you, Madhubhashini. Thank you, Murlidhar. There was a comment, Murli, about the wonderful and mellifluous sound of that were coming when you were speaking. And I said that our campus is full of birds and nature. So thank you for sharing. We also heard Madhu's dog barking. And so it was lovely to embrace the whole NEESAMA community and their extended families and their extended pets into this family. Thank you everyone for joining. I hope you benefited and enjoyed from the discussion. All those who put questions, thank you very much. We hope to see many of you in the webinar on 20th. In the meantime, take care of yourselves, be safe and be healthy. Good day to all of you.